Can you guys hear me clearly?
Yes.
Okay, thank you. So, okay. So, thank you very much. Maybe you can check back, Prof, on the audio from your side. So, we're going to have 35 minutes of lecture from Dr. Anza Elias, and we will continue about 10 minutes of question and answer, and later on we will have about a few minutes of promotion on ACOH, and to introduce to all of you about what is ACOH and how do you register and show your interest to ACOH to us. Okay, thank you very much. Okay, next. So we're gonna start with our session for today. So let me introduce Dr. Anza Elias. Dr. Anza Elias, as I mentioned, is a council member of Academy of Occupational and Environmental Medicine Malaysia, AOEMM. And Dr. Anza Elias is a very experienced person, is a public health medicine specialist with more than 2 decades of experience in occupational health, not only in Malaysia, but in the international stage, especially in the Middle East. She is the council member of AOEMM, as I mentioned, and having some advisory role to few companies. Dr. Anza holds postgraduate degree in public health medicine and occupational medicine, and actively lead initiative in occupational health services. Knowing Dr. Anza in person, I think she is very experienced, and she is very someone that willing to share her experience and trying to promote the fraternity to all of the young generation. I think without further ado, let me invite Dr. Anza to deliver your presentation. Dr. Anza, please carry on.
Thank you very much, Dr. Faiz. Assalamualaikum and good afternoon to all. Can you see the slide, Dr. Faiz?
Yep, Dr. Anza, very clear.
Yes,
and your voice also very clear.
Okay, good. So what I would like to share with you for the next 35 minutes is to look at what are the main components of the occupational health, and then I will share with you with how we're going to combine clinical occupational history and expert data for accurate diagnosis of occupational diseases. Thirdly, we're going to share with you how we're going to apply established diagnostic and exposure criteria. And lastly, I will share with you how we're going to implement primary, secondary, and tertiary prevention strategies to reduce occupational disease burden. So I know it's post-lunch, so let's go back to the very basic of occupational health. So it's a two-way interaction, how work affect health and also how health affect work. Okay, now in your chat box, can you give an example, a condition where work affect health? You can put it in your chat box. I know it's post-lunch. Anyone would like to share your thoughts? How work affect health? Anyone? Somehow I cannot see the chat box. Faiz, anyone responded? How work affect health?
Okay, wait, let me check.
How I don't have any access.
If I can read, Dr. Anza.
Sure, sure.
From Ame, from Hauri Iswanto, sleep this. And then Ame mentioned about sleep and stress. Nurul Darwina answer stress. And then Fazli answer workload. Joshita answer ergonomic. And Siti Nurhafiza answer high stress, workload, hazard exposure, burnout. Oh, so many answers.
Right. So that's okay. So that's how work affect health. I will share with you in scientifically, it's about how work affect health is about occupational diseases. The things that we're going to learn today, share with you today. Okay. How about health affect work? So health affect work is about how a diabetes patient, poorly controlled diabetes in a driver could affect his work, his safety at road. So that is an example of how health affect work. Okay, so as I mentioned just now, occupational disease is an illness, meaning a well-established can be diagnosed in ICD-11 as a result of exposure to hazards at work. Okay, because of the job activity. Okay, so what we need to understand is factors in the work environment are necessary in the causation of the occupational disease. So it's cause specific. So lesson number 1, association does not mean causation. Okay, so that's the EPIC lesson number 1. So it's cost specific. So what the answers that you gave to me is burnout. Yes, burnout is in ICD 11, but it is for organizational diagnosis. Okay, stress is not a diagnosis. Okay, stress is condition. Okay, so therefore, for us to have a very strategic, very specific prevention, we need to have accurate diagnosis. Without an accurate diagnosis, we are shooting in the dark. As a result, we get ineffective workplace intervention. So that's why we must have an accurate occupational disease diagnosis. So these are the examples: silicosis, asbestosis, okay, occupational loss, induced hearing loss. So these are the diseases. All right. So how about work-related diseases? So the definition is the diseases in the workplace where work factors may be one of the reasons. Okay, so it's not cause specific. It's the workplace is one of the reasons for the occurrence. So these diseases are multifactorial, and they are seen in general community. So these are the examples: ischemic heart disease, musculoskeletal disorders, and cancers. So we need to understand, so these are the differences. So because we need to have a specific preventive measures, we need to understand diseases and what is meant by work-related diseases. So for occupational diseases, it's cause-specific, right? For work-related, it's multifactorial, and for occupational diseases, it's likely to be notifiable and compensable, but not for work-related diseases. Okay. So when we look at occupational diseases, so there is a list. So in ILO, for Malaysian candidates, so this is the one that we have under Occupational Safety and Health Act, and also under Employee Security Act. So these are the lists. So we have the list because it is cost specific. So when we look, so this is the ILO list of occupational diseases. So someone mentioned to me about sleep disc. So when you see here, what you can see here is for musculoskeletal disorders, sleep disc is not here. Why? Because it is multifactorial. And there is a clause. Here is other musculoskeletal disorders not mentioned in the items, where a direct link is established scientifically or determined by methods appropriate to national conditions and practice. So the key word here is established scientifically. So I'm sure most of you remember about Bradford Hill criteria of causation. So that's why it is important for us to understand the reason, the reason, and also how those team come up with a list of occupational diseases. So this is formulations. So this is in the one of the acts. So for carpal tunnel syndrome, this is the clinical diagnosis. So what are the exposure to say that carpal tunnel syndrome is an occupational disease where the exposure involves highly repetitive movements, forceful exertions. So these are the definitions. So I know it's a bit general, but I will show to you what else can we see, how we're going to apply that. Okay, so this is from Malaysia again, for tuberculosis and leprosy. Okay, so these are the nature of activity and occupation. So you can see here, these are the clinical diagnosis and these are the exposure. So again, hearing impairment, any occupation involving excessive exposure to noise at work, more than 85 decibels in over 8-hour period. So this is the exposure. Right. Why do we need to have a criteria? Because number one, just like any diagnosis in medicine, we need to have a diagnostic criteria because we need to have consistency among doctors. We need to have a proper treatment, and we need, as I mentioned just now, we need to have a strategic preventive measures. We need to have surveillance, because in public health medicine, we need to have valid, accurate data. Without valid and accurate data, we cannot have a proper preventive measures. So the next one is compensation and of course litigation. Right. So how do we diagnose an occupational disease? So this is just an overview. Is a causal relationship which is established based on clinical data, based on the exposure at work and job task analysis. We need to we need to look at the data, the exposure data, and lastly, we need to look at the other roles of role of other risk factors, because what we need to understand is most of the time diseases are multifactorial, so that's why we cannot forget about other risk factors. So it is an example of applied clinical epidemiology. So that's what I mentioned to you about Bradford-Hill criteria. So, okay, and we need to, in Bradford-Hill criteria is about temporality, whether it can be reversed or not. We need to look at exposure response. We need to look at strength of association and specificity, and we need to look at biological plausibility. So this is how we get the list. Okay, so let's look at the relevant exposure data. So this is in ILO, it has to be minimum intensity, minimum duration, maximum latent period, and induction period. So when you take the history, we not forget to take this history, because we want to have an accurate diagnosis. So I've explained about the overview of occupational diseases. I explained about the differences between occupational diseases and also work-related diseases. Now, let's look at how we're going to diagnose an occupational disease systematically. So number one, because this medicine, we look at presented illness, we need to do examination and investigations. It's all the same. So secondly, we take occupational history. And thirdly, we need to correlate symptoms with the job task. And also we need to verify that with the exposure data. And then fourthly, after we gain all the information, we need to apply with the established diagnostic criteria. And lastly, about the management. So it's end-to-end process. We need to diagnose properly, accurate diagnosis, and we need to manage the workers. We need to manage the workplace. Right. So this is as we understand from medical students, we need to document the symptom onset, duration, progression, whether it's acute or chronic, okay? And then secondly, we need to look at how we're going to take the occupational history. So as we know, job title is not educate, okay? So we need to identify other exposures must be clearly documented. We need to document the exposure. It's about how it is being done, how many hours per day, how many times per day, whether it is done by with a group of colleagues or not. And then we need to look at, because we do have to rule out other differential diagnoses, we need to ask about non-occupational exposures and hobbies as well. So this is just an overview of occupational history. And then we need to take the history of the control measures, right? Such as injury control, administrative control, and PPE. For the PPE, we need to ask whether they are wearing correctly, because if they don't wear PPE correctly, then it is not effective. Okay. So we need to ask about occupational and non-occupational factors as well. Okay, and other part-time jobs. So then, after we take all the presented illness, and then we ask about the exposures. Now we need to correlate symptoms with the job task. Okay, so we need to analyze whether the relationship between the symptom onset, such as in occupational asthma, right? So we need to assess whether the symptoms improve during periods when they are on leave, right? And we need to evaluate whether the symptoms are present in other colleagues as well. So then we integrate the occupational and non-occupational risk factors to assess and to come up with a conclusion. Okay, so what I need to remind you is, yes, we take the exposure history from the patient, from the employee, but we need to verify with the workplace exposure assessment data. So these are the examples: a noise risk assessment, we have chemical health risk assessment, and ergonomic risk assessment, because these are our tools to look at the exposure. So it's a quantified risk assessment. So when we take history, we cannot assume that we cannot verify, and they are just qualitative information. So the workplace exposure assessment data, these are the quantitative data that we need to rely on when we're going to diagnose and occupational disease. So this is an example of a noise risk assessment. This is the area monitoring. Okay, so these are whether this is the type of noise, whether it's steady, whether it's intermittent. So what you can see here is continuous noise. So this is from personal exposure monitoring, person. So what you can see here is for row number 2. So the exposure, the personal exposure is 85.7. So the ones in red are above the noise exposure limits. Okay, so that is what I mentioned to you, is quantified, because by interviewing the patient, we cannot quantify the exposure. Okay, so to conclude about the exposure criteria, in diagnosis and occupational disease, we need to have sufficient occupational exposure. And how we're going to do that? By taking history, we need to look at the control measures records, and we need to review this noise risk assessment data, chemical health risk assessment, ergonomic risk assessment, and of course we have biological monitoring results. So that's what is meant by looking at the exposure criteria systematically. Right. So after that, we apply the information that we gather to an established diagnostic criteria. So the established diagnostic criteria there are many of them. So we have ILO, we have EU, we have ASEAN, and for us, Malaysia, we do have from PECESO, it's our social security body, right? So we utilize clinical investigations, and we need to compare to ensure that the minimum threshold for exposure intensity are met for occupational diseases. So I will show you the example. So what we need to understand is, after we reached a clinical diagnosis, then we apply to the established diagnostic criteria to confirm whether it is indeed an occupational disease or not. Okay, it is evidence-based criteria, so it's not your gut feeling. It has to be evidence-based. Okay, so this is example. This is from ILO, this is from EU, and this is from our Malaysian guidelines for diagnosis of occupational disease. So, so this is an example for this from EU. So this is what I meant by minimal intensity of exposure. Look, they have above for silicosis, yeah, the exposure must be above 50 microgram per meter square. Okay, minimum duration 5 years. So that's what is meant by that. Carpal tunnel syndrome. Okay, carpal tunnel syndrome, the exposure criteria is more than 10 items handled per minute, or 20 hand repetitions per minute, and high force 1 kilogram handle weights. So these are the criteria, the minimum exposure criteria. So this is from the EU as well, and ASEAN is similar. So this is an example of decompression illness. Okay, so just to recap, we need to take history from occupational disease, presenting illness, and then we need to take occupation history, and then we need to look at the exposure, right? We need to look at the exposure data and then apply to the standards that we have. Okay, so most standards are available online. For example, ILO, EU, or ASEAN, they are available online. So now we're going to go to the management of occupational disease. So why did I went into details of how we're going to diagnose and occupational disease? Because without accurate diagnosis, we cannot manage occupational disease effectively. Right. So in occupational health, the principles are the same. Okay, we manage the person, the employee, and we manage the workplace. But first of all, it's about the patient, the human. Okay, why it is important? Because we need to address the current issues. For example, occupational asthma. We need to address the clinical symptoms first, and then we need to advise how to refer if needed, because we want to prevent the reoccurrence of the illness. Okay, then we're going to manage the workplace. And lastly, of course, we need to assist in the compensation process, because in most countries, there would be a list of compensable occupational disease as well. So that's why it is our roles for doctors to assist in the compensation. Right. So just what I've explained just now. It has to be our role is to support accurate diagnosis. It is evidence-based approach. We need to remember about to exclude. That we need to remember about differential diagnosis. We need to exclude non-occupational causes as well. Okay. So from that, we need to have primary prevention. So what is meant by primary prevention is we go through the hierarchy of control. So elimination, if you can, right? We implement administrative control or agent control, and lastly, provide appropriate PPE. So most of the, I think for occupational safety and health, mainly they would advise this, but we need to understand, we need to also do secondary prevention, such as early detection through health surveillance. So some countries, the surveillance would be hazards based. Okay, but in other countries, the health surveillance is disease based. For example, in the UK, they have hand-arm vibration syndrome, so it's disease based, or occupational asthma. So so it depends on which country we're talking about, but the outcome of the exercise or the implementation is to make sure that we have specific preventive measures for the workers at risk. Okay, because we want to we want to remove the exposure if the disease is detected. And lastly is a tertiary prevention. So, for example, those workers with occupational noise-induced hearing loss, we need to assist them for rehabilitation, to assist them to refer to the ear, nose, and throat specialists and audiologists, whether they need to have hearing aids. Okay, and we need to support them for return to work programs. So for those non-Malaysians, in Malaysia, we do have an established return to work programs by our social security called PEKESO. Okay, and also we can assist in the compensation and support for affected workers. Right, so I addressed this as well. We have clinical management, I've mentioned that, and workplace intervention, right? So for workplace intervention, for workers, we can assist them to modify work tasks or environment to prevent occurrence. So, for example, those with diagnosed with occupational asthma, so we we can say that, look, this person, the exposure is to certain chemicals. So this worker will be removed from being exposed to certain chemicals to prevent recurrence. Okay. So for the next one will be compensation. So it depends on the legal framework for your country. For Malaysians, we have Employee Social Security Act, but we need to provide a good service to the worker in providing medical reports. We need to provide exposure assessments, the one that we had just now, NOS risk assessment, economic risk assessment, and workplace investigations to support whether this an occupation disease or not. And also we need to assist the patients in assessing compensation and rehabilitation services. Right, so next we go on to the compensation for occupational diseases. Okay, so sorry, it is in Bahasa Malaysia. So this is for government workers where we have ex gratia for compensation. Okay, so this is an example. Sorry, again, it is in Bahasa Malaysia. So this is for workers who will be eligible to get compensation due to occupational disease. So these are the forms. Right. So lastly, I would like to have 2 case studies. Okay. Case number 1. A 45-year-old female secretary presents with bilateral hand numbness and tingling was at night. She is overweight and she has diabetes. So she uses computers 6 to 8 hours daily, but of course not continuously. So she uses it for emails, report writing, online meeting, right? So from the ergonomic risk assessment, because the keyboard is soft, right? So there is low intensity of repetitive movement. So, and she's been working for the current role for 10 years, and she is provided with ergonomic keyboard and mouse. Okay, so this is a clinical evaluation because we need to establish the clinical diagnosis first. So these are the symptoms: physical examination, Tyndall and Fallenstein positive, and nerve conduction study, median nerve compression, and we can clinically we diagnose her with carpal tunnel syndrome. Okay, so question number 1, right? What occupational factors were assessed to determine if whether her carpal tunnel syndrome was an occupational disease? What are the occupational factors? Anyone? I just try to.
Any answer from the audience?
Okay, now I find the chat box. Okay, I can see the chat box now, Faiz.
Okay.
Okay.
And you guys also can add in your question later. Just be reminded on.
Yeah. Anyone would like put in your chat box? What occupational factors would you assess to determine whether the carpal tunnel syndrome is an occupational disease or not? Remember the ones that I showed to you from ILO, from yes, nature of work. Yeah, more specific, please. Tasks, intensity, long term. Yes, ergonomics, but what are the specific? Yes, repetitive tasks. Okay. Any of repetitive strain, prolonged use. Yes. Now go back to the ones that I shared to you in the EU and ILO diagnostic criteria for exposure in occupational carpal tunnel syndrome. Awkward posture. Right. Okay, I'll give you the conclusion later on. How many? Yes, Nazri, thank you. How many repetitions per minute? Exactly. Right. So, Musa, you are answering number 2. Yes. What are the personal risk factors? Yes, obesity and diabetes. Yes. Right. Yes. Okay. Wanurasha, you are correct. Repetitive and forced movement. Okay. So that would be the answer. Okay. So, question number 3. Is the carpal tunnel syndrome in Miss X is an occupational disease or not? Okay. Zana said yes. Okay, yes. Everyone's okay, yes.
Majority, yes.
Majority, yes. Vitamin B12 deficiency. Okay, so Kaplesh said no. Azizan said no. Okay. Still need more information.
Okay. One answer work-related disease.
Yes. Okay. The correct answer is no, it is not an occupational disease. Okay. Let's go back to here. Okay, so this is from EU, right? So ASEAN will be the same as well. So minimum exposure is repetitive and forceful hand use. Forceful. The key word here, repetitive and forceful. So this is the criteria, and this is the criteria. Highly repetitive, 10 items handled per minute or 20 repetitions per minute, and high force. So my question is, does the modern keyboards are soft or hard? Yes or no? My question is, the modern keyboards, soft or hard? You can answer in the chat box. The modern keyboards. Now we have the modern keyboard here. Here. Soft or hard? Yes, soft. Yes, exactly. Soft. Yes, correct. So it cannot be high force. Repetitive, I mentioned to you just now, it's just not continuously. So they would not be continuous typing. They are not data entry and awkward position, right? So the answer is not an occupational disease, but more likely of work-related because typing worsens symptoms. Okay, and her personal risk factors are the dominant ones, the one that contribute to the disease. Okay, so she does not fulfill the criteria. Highly repetitive 10 items handled per minute or 20 repetitions per minute or high force. Okay, so good. So you see how you're going to apply that? Refer to the established diagnostic criteria. Okay, need more information. We need to have the ergonomic risk assessment. So ergonomic risk assessment, just soft, right? So repetitive, but not continuously. Okay, so I know my time is limited. Okay, so this is next case. A 52-year-old male worker with bilateral hearing loss and tinnitus exposed to 89.5 decibel of noise for 25 years. He does not wear hearing protection consistently. Right? So question number 1. What are the workplace exposure data would support the diagnosis and occupational disease or occupational and IHL? Anyone? Put in chat box. Yes, noise risk assessment. Is excellent. Yes, excellent. Yes. So number 2, what clinical findings are characteristic of occupational and IHL? So sorry, just to retract. Okay, I know it's an noise risk assessment, but specifically which in the result, which area in the result, which are the components that you would refer to? Sorry, I retract for the question number 1. Which specific area in the results that you would refer to? Do you refer to area monitoring or do you refer to personal exposure monitoring? Yes, you refer to personal exposure monitoring. Yes, correct. Yes. Good, excellent. Okay, so go back to number 2. What are the clinical findings that are characteristic of occupational NHL? What would be the clinical findings? Yes, deep with recovery, excellent. I am bilateral hearing loss. I'm looking for another keyword. Yes, Dr. Nadia, sensory neural hearing loss. Excellent, yes, sensory neural hearing loss. Okay, so sensory neural hearing loss with notch or dip at 4 to 6 and improvement at 8. Excellent. So number 3, what factors confirmed the occupational NIHL? What factors confirmed the occupational NIHL? Remember the one that I mentioned to you, get the history, get the exposure, apply to the standards. Yes, Dawina, excellent. Exposure, yes, duration exposure, right? Okay, exposure to noise exposure limit above noise exposure and the occupational history, which has been exposed to noise for more than 20 years. And also he did not wear the hearing protection that even slight removal for when someone removes the hearing protection, even for a few minutes, the effectiveness of the hearing protection will reduce significantly. Okay, so yes, so your answer is correct. Exposure more than 10 years. So go back to the diagnostic criteria in ILO, in EU, or in ASEAN, or in for Malaysians, we do have a per CASO guideline. Okay, so yes, 25 history, right? Without proper wearing the hearing protection effectively, we have bilateral high frequency notch. Okay, right. So these are the examples. Okay. Okay, so just to recap, okay, audiometric tests. So those are the audiometric tests, Theo. Yes. So just to recap, step number 1, we get the occupational history. Okay. So we asked about this countermeasures, and then we need to look at symptom work correlation. So remember, association does not mean causation. Okay. We need to look at the exposure assessment. All right. So diagnostic criteria, we use the international national guidelines. We need to look at the workplace measurement, the one that we had just now. We looked at noise risk assessment, and then we need to exclude non-occupational diseases causes, because most of the time it's multifactorial. Most diseases are multifactorial. And then for the prevention, we need to have primary intervention, secondary intervention, and tertiary intervention. And we need to we need to manage the workers, and then we need to manage workplace. Manage the workers would include workplace modifications, and these are the compensation. Okay, we must provide the accurate medical reports, which includes all this, right? Workplace assessment to show that it is indeed an occupational disease, and to assist the claims. Okay, so to conclude, diagnosis of an occupational disease is an evidence-based medicine approach. It is an applied clinical epidemiology, right? So diagnosis of occupational disease is based on diagnostic criteria. So thirdly, we need to have valid exposure data. And lastly, from all this, then we can have effective preventive measures. So Dr. Faiz, that's it from me. I know I'm 3 minutes late. Anyone would like to have any questions?
Okay, thank you very much, Dr. Anza. Can you hear me very clearly?
Yes, yes.
Yes,
Okay.
Doctor.
Okay. Phew, I just lost just now. I just come back. So thank you very much, Dr. Anza. As I mentioned, without doubt, Dr. Anza is a very knowledgeable and very teacher-like character. So I think whatever that has been given by Dr. Anza is very clear and very insightful. Okay, actually we have one question that I saw. Maybe you all can actually post your question again here. Let me read the first question. Sorry for my camera, I cannot open yet. But let me continue with the session. I have one question from Surendran Aji. The question is, Tanza, is return to work a regulatory requirement in Malaysia? Is it based on the documented return to work program between employee and employer, or only a plan recommended by the occupational health doctor? So what are the main component of an ideal return to work program? So that's the question, Dr. Anza. So the first question is return to work a regulatory requirement in Malaysia?
It is under Social Security Act, but I believe I need to ask my Pekeso team whether it's a really regulatory, but they do have a structured return to work program, but I'm not sure whether they do have any penalty for employees who do not follow the return to work plan by the case managers. So my answer is yes, they do have in the structure of the in Social Security Act, but I'm not sure about whether it's a penalty or not. Yeah, the second question, Faiz.
Okay, second question, I think you already answered. Is it based on documented return to work between employee to employer, or only recommended by the OH doctor?
It is documented by the case manager of the by Social Security Agency. In Malaysia, we call it Pekeso or SOCSO in English.
Yeah. So sometimes if is it from the private staff, okay, they maybe under SOCSO, but for the public staff, sometimes we as a OH doctor, we also actually can offer a prescribed return to work lah. Okay, we are waiting for other question, Dr. Anza. I maybe can ask question. Okay, there's one more question from Muhammad Irfan bin Muhammad Saleh. Salam doctor, I have one question on diagnostic criteria of WMSD based on the ILO and the European guideline. The diagnosis of certain medical condition is only mentioned in the guideline. However, WMSD can also be sprain or strain. Which diagnostic criteria do you suggest, doctor, on WMSD?
Okay, this is a common question, Dr. Muhammad Irfan. So in the ILO and EU guideline, those are the diagnostic criteria. So for sprain and strain, they are multifactorial. So that's why we cannot quantify what would be the exposure, because it's acute. Sprain and strain is acute. So by definition, occupational disease is long-term. It is not acute. So my answer to you is that there is no diagnostic criteria for sprain and strain, because sprain and strain is that particular moment, that particular incident that can cause sprain and strain. For occupational disease, it's repeated exposure. So that's why in ILO, in EU, in ASEAN, or in Malaysian Pekeso guideline, there is no sprain and strain because it's not an occupational disease.
Yeah, okay. Thank you very much, Dr. Anza. So next question by Dr. Eng Nagwa Fat Bashir. Are they, according to regulation, specific per medical checkup check for each occupation?
No, under the specific regulations, there is no medical checkup of fitness for work for each occupation. There is none. There is none.
Okay, so there's none. Okay. Next question by Theo. Is that mean the employee obtain more than 4 days only need to do return to work?
No. So an MC of 4 days or more than that, it would depend on the diagnosis of the medical condition. If let's say it's just an acute condition, then we do not have to have a return to work program. So for per case, so I'm assuming, I'm not sure whether Tio is a Malaysian or not. If let's say someone is from Malaysia, return to work program in per case, so it would mean the medical leave or sick leave for more than 2 weeks or more than that. So we cannot have an acute condition to go through the return to work program.
Okay.
So it
Thank
depends
you.
on the medical condition,
Mm.
not just the number of medical leave.
Okay, not number of the medical leave lah. So the
Yes.
medical leave, I think, is more on notifiable disease lah, eh?
Yes, correct.
Okay.
Yes.
Okay, thank you very much, Dr. Anza. I think we still have time to actually have question. While waiting for question from audience, I think I have one more question, Dr. Anza.
Sure.
Based on your based on your experience as an occupational health specialist industry in Malaysia and in overseas, and I'm sure you will agree with me. One of the challenges of us in the fraternity is actually to get cases that we refer. So either we are at the secondary level getting cases referred by doctors, or we are actually in the organization where we are the one that catch up, get the case and try to do prevention lah. So let's say, so my question is, what is the challenges as an occupational physician to get cases, for example? So just now you mentioned about occupational disease and so on. So do you think that is still any gap to be improved in terms of, you know, identifying occupational disease cases for management?
Yes. For me, the challenges is recognizing the exposure at work. And what we have now, if, for example, we do have the clinical diagnosis. So clinical diagnosis of, let's say, asthma.
Mm-hmm.
Okay, so we do have clinical diagnosis of asthma. If someone does not take, if the doctor does not take a good history of asthma, then we cannot diagnose this is indeed an occupational asthma, because most of us, maybe it's during my time, I'm in the X generation, so maybe we were not trained how to ask what you're being exposed to. For non-occupational health. So if we do not ask about the occupational exposure, then we cannot diagnose occupational asthma. So for me, one of the challenges is we do not ask deep enough. Number two, number two is the occupational health literacy among health and safety professionals is a bit low. Okay, what I mean is, yes, we do have limitations with doctors who do not ask enough about the exposure. Now we have the safety and health and safety professionals who do not think about the exposure at work, which may contribute to the illness. So those are two main issues that I would recognize. And how we're going to solve this is to promote more to the doctors, the specialists, and the specialists which are not in occupational health. We need to train more for non-doctors, for the health and safety professionals.
Yeah, I agree with that. I think one of the issue is to diagnose a clinical, to come up with a clinical diagnosis is okay as a doctor, but to decide on the work relatedness, that's the issue. I think maybe the doctor, we don't expect you guys to, you know, GP and the doctors, we don't expect you guys to go very deep, but at least you can ask more questions and refer so that we can actually continue with that. Okay, I think we have two more questions, Dr. Anza, very fast one.
Faiz, that's Dr. Bashir from ACOH. Sorry, he's my friend, so that's why I know him. From ACOH Abu Dhabi. Thank you for joining us. Dr. Bashir has a question, I believe, but we cannot unmute him, right? Can we unmute Dr. Bashir? Sherry? I don't know.
Dr. Bashir can unmute. Yeah. Can we
Bashir,
try, Sherry?
Sorry, I'm not.
Yes.
Yeah.
Okay, while waiting for that, Dr. Anza, can I read
Yeah.
first? Okay. There's a question from Zainal Zulkifli. Are there any international guideline from ILO for the WM, work-related mental disorder or stress?
No, there is none. There is none for work-related mental disorders, but in the list of ILO, for mental illness, there is only one: post-traumatic stress disorder. Okay,
PTSD, right?
PTSD. That's it in the list. Okay, for work-related mental disorders, whether such as anxiety, depression, or bipolar or schizophrenia, there is none. Because why? Because it's multifactorial. It's not easy to pinpoint and quantify an exposure. So unlike noise, we can measure using sound level meter or dosimeter, right?
Yeah.
But not.
Objective measurement.
Yes, we do not have object management. So even though we do MRI, we cannot do that. So that's why. And stress is not an illness. It is not in the ICD-11. Stress is just a condition. So Zainal, there is no international guideline from ILO or any other international bodies. Yeah.
Yeah. Okay, Dr. Anza, because of the time restriction, I think one more question by Faiz. That's not me, but another Faiz. Is it compulsory to have ERA, economic risk assessment, in assessing occupational PID, especially for medical board?
Yes. I'm speaking on behalf of my friends in the medical board, medical specialist in Ministry of Health Malaysia. Yes, because we need to quantify the exposure. But my take is the economic risk assessment must be valid. Okay, so invalid assessment would result into the invalid conclusion. Yes.
Yeah. Okay. Thank you very much, Dr. Anza. I think one more question Dr. Anza already answered. Is carrying risk assessment part of diagnosing of OD? Yes, it can actually help on diagnosing of OD also lah. Okay, so I think
sorry, attendance. There is any attendance? Someone asked for non-Malaysian. I think Sherry would have that as well.
Yeah. So
Dr. Ansa, if allow me to say,
Sure, Dr. Bashir.
I said 10th revision define the one of the where we can refer about the occupational diseases with respect to mental health. Is that 5.6.6 other physical and mental strain related to work? That's how we can able to influence psychologists and psychiatrists and OH physician to diagnose occupational stress. Going forward to the questions about awareness, maybe if Malaysia and other Middle East, other countries looking into giving awareness to all the physicians, especially pulmonologists, to report occupational asthma and look into high risk industries where they deal with chemicals, especially from the SDS point of view, those who are asthmagen. That may be the starting point, and where all these people go on those referral clinics, giving awareness will help the doctors to understand. That's my point here.
okay, thank you very much.
Agree. Yes.
I'm happy to have Dr. Bashir here. Of course, Dr. Anza's friend is my friend also, our friend. So I am looking forward to see you, Dr. Bashir, in our upcoming ACOH. Okay. So with that, Dr. Anza, I'm very, very happy, and I think all our audience will be very happy and delight with whatever input that we actually obtain from you, Dr. Anza. And for any other question, you guys please email to us. We will shoot in our email later. We will try our best to get Dr. Anza to answer that. Okay, so let's move to the next agenda, Shakira. Okay, so this is one of the most important agenda. I'm sure you guys are happy with the input given by Dr. Anza, and believe me, you will get more in the upcoming ACOH 2026. They're going to happen to be held in 5th to 8th August in Borneo, Kuching, Sarawak. For all Malaysian, you are welcome, of course, to Sarawak, and for all international participant and audience, you are very much welcome to come to Malaysia, not only to join our ACOH 2026, but also to come to Malaysia and visit Malaysia, a very beautiful country. Okay, so next, maybe we can get a video. Okay, enjoy our promotional video, dear gentlemen, ladies and gentlemen. Can we have the sound, Shakira? For information, this video can also be obtained, or you can also watch this video in our ACOH website. Okay. Okay, let's enjoy our video as a teaser for our ACOH 2026.
This is a new horizon. One we'd never imagined. In a land as old as time lies the ancient wisdom of mankind. We are all in search of something greater, to find meaning in mysteries long forgotten. What if we went back to where it all began and reconnect with our origin? Now feel the rhythm of Sarawak. This is our prayer for the world. May you come alive even in the stillness, as you awaken to newfound senses. May this life be a more immersive journey for as far as you wander. Sarawak, your journey begins here.
Yeah, so we look forward to see all of you in the upcoming ACOH. So I'm sure all of you will ask, how do you register? Okay, let's proceed to the next part. Okay, so this is our upcoming webinar. We offer all free webinar for all of you, and we bring all experienced personnel, big personnel in the our fraternity to engage all of you for the next. So we have Dr. Zainal Mubarak Zainuddin, Industrial Hygiene Consultant Malaysia, with the webinar title Essential Industrial Hygiene Concept for Occupational Health Doctor. And we have our very own Dr. Azlan bin Darus, the Head of Prevention, Medical and Rehabilitation, SOCSO, with the topic of protecting the workforce security under SOCSO. Okay, so this is the next webinar by the Mr. Zainal Mubarak Zainuddin. Okay, next. So this is the upcoming webinar that we're going to have. Next one, Shakira. Okay, so please register your interest. I give you time to scan this QR code to register your interest, so that when we get your detail, we will send further information on ACOH. Okay, few more seconds. Okay,